need to thank me for doing all the hard work, did all the slides for this presentation. So we're going to talk really about the liver. So why does the liver matter in diabetes and obesity? So the liver is central to glucose and lipid homeostasis, and in diabetes and obesity, hepatic metabolic regulation becomes deranged, and this results in cardiometabolic risk. Now, this is a bidirectional relationship. Hepatic steatosis increases the risk of incident type 2 diabetes, while established type 2 diabetes can accelerate the progression to NASH, fibrosis, cirrhosis, and even hepatocellular carcinoma. Hepatic insulin resistance is the primary metabolic abnormality underlying liver-centric disease. But remember, weight loss is still a primary mediator of hepatic benefit by reducing the adipose-derived fatty acid delivery, free fatty acid delivery to the liver. So these are the steps that we find when we're looking at MASLD or MASLD. So remember, adipose tissue insulin resistance results in uncontrolled lipolysis, delivering excess free fatty acids and glycerol to the liver. This results in lipotoxicity and inflammation. This accumulation of toxic lipids intermediates triggers hepatocellular injury, Kupffer cell activation, and inflammatory signaling, which can then lead to fibrosis. So we can go from simple steatosis to steatohepatitis and on to advanced fibrosis and cirrhosis. So that's the entire disease spectrum. So when the liver is the target, treatment goals extend beyond glycemic control in our patients with diabetes. So what are the objectives? The objectives are, number one, reducing hepatic glucose output. Number two, decreasing liver fat content. Number three, improving hepatic insulin sensitivity. And number four, suppressing inflammation and reducing fibrosis risk, and thereby modifying disease progression. So we're talking about the drugs that we use for glucose and obesity. So glucose-lowering drugs principally. And I think we need to really concentrate on maybe the newer agents. So that's in the middle of this panel. So the GLP-1 agonists and the dual agonists. So we know that these have an indirect action on the liver, okay? So they will be of benefit in MASLD, but it is indirect. They're not directly acting on the liver. So the GLP-1 receptor agonists and the dual agonists increase insulin levels, and other medications such as the SGLT2 inhibitors also have an indirect effect, and they reduce insulin exposure and hepatic metabolic flux. So I want to also concentrate on how we diagnose MASLD. So I don't know if you guys in your clinics are using a FIB-4. Remember, this is used to calculate the risk in our patients. It uses AST, ALT, age, and platelet levels to give us the risk. So a level above 1.3 indicates some degree of MASLD. So we should always calculate this in all our patients with diabetes or obesity as the first screening tool. The next screening tool is going to be imaging. So this can be with transient elastography. And here we're looking at the liver stiffness measure. Over 8 is going to give you an idea that there is some degree of fibrosis. And we can see here in this management protocol, this is the way risk is determined, either low risk, intermediate risk, or high risk when we have a FIB-4 over 4 and a liver stiffness measure over 12, or liver biopsy showing frank fibrosis. So what are the management steps? Lifestyle intervention. This is necessary for all risk categories. Weight loss, yes, is necessary for all of these categories. But pharmacotherapy is not really recommended at low risk level. It's after intermediate risk that we would start thinking about medication. Remember, cardiovascular risk reduction is essential in all categories. So managing the lipids, managing blood pressure, managing, obviously, glucose control. And diabetes care, we're going to try and look for medications with efficacy in MASH. So this is going to be principally pioglitazone or GLP-1 receptor agonists. And if they're at high risk, this is even more essential. Now I'm going to hand over to Nimi.
Rupa ma'am. So when we talk about the anti-diabetic agents, we talk about their effects on liver. So when we are looking for the enzymes reduction, especially ALT levels, we primarily use pioglitazone. If we are looking to AST reduction, we go for DPP-4 inhibitors, and we are looking for a GGT reduction, their GLP-1 receptor scores. Now when we are looking for the liver fat effect, then TZDs do not really specifically have any reduction in liver fat, but DPP-4 has slow or to minimum effect, and GLP-1 has actually recorded the highest probability for reducing steatosis and liver fat. SGLT2 inhibitors do not directly help in enzyme reduction, but definitely has superiority in reducing liver fat fraction. When we are talking about NASH resolution, it's only TZDs and GLP-1, they have significant some or other effects, especially semaglutide and liraglutide. But on fibrosis, sadly, we have nothing that works and gives a consistent regression. Now, when we talk about the glucose lowering agent's effect on MASH, we predominantly look into GLP-1 RA, dual triple agonist, and pioglitazone, and in some cases SGLT2, not DPP-4 and metformin. When we talk about GLP-1 RA, we all are aware about the effects of GLP-1 RA, but what we often miss is its use in MASLD or NASH patients, because with lowering HbA1c, improving insulin sensitivity, it improves in all metabolic parameters, it reduces hepatic fat content, it improves the liver stiffness, improves body composition, has some effect in fibrosis biomarker, and definitely improves liver function tests. Along with the pleiotropic effects of GLP-1 RA, including increased satiety, decreasing appetite, increasing glucose utilization, reducing lipolysis, gastric emptying reduction, increases insulin, reduces glucagon. Along with all these pleiotropic benefits, it also increases hepatic insulin sensitivity, it reduces gluconeogenesis, glycogenolysis, and improves VLDL and TG production secretion, which in turn leads to reduced hepatic inflammation, reduced hepatic steatosis, and increased MASLD or MASH resolution. Now this is very important ESSENCE trial that was done with semaglutide 2.4 milligram once a week for 72 weeks, where 800 patients of MASH, they actually showed improvement. Almost 30% of the patients on semaglutide showed resolved steatohepatitis with no worsening in liver fibrosis, so we can safely use it in liver fibrosis. 16% of patients have combined resolution of steatohepatitis and fibrosis. There was 8.5 kg body weight change, and there was 14% patient who showed improvement in liver fibrosis and not worsening in steatohepatitis. So when we talk about liver disease, why we want to include weight lowering or anti-obesity medicine is because its direct effect on improving liver health. Now, this is the study with tirzepatide. There are emerging evidence that surpass 3 MRI sub-studies demonstrating that up to 8.2% absolute reduction in liver fat content over 52 weeks. So if you see patient on tirzepatide 15 milligram showed 62% resolution of MASH and no worsening of fibrosis, and the common dose that we use here in India is 10 milligram more or less, so it showed 56% improvement. So when we talk about type 2 diabetes and liver diseases, especially MASLD, we do look into intensive lifestyle modification as it remains the base of treating liver disease with targeting more than 10% weight loss. First line pharmacotherapy is usually metformin. Modern adjuncts like GLP-1 RA and SGLT2 inhibitors, they help us achieve weight loss and reduce intrahepatic fat. And when the patient is having NASH or has high risk disease, we commonly use pioglitazone or saroglitazar here in India. So when we are talking about liver disease, we have to look into dominant clinical phenotype, what we are treating along with liver disease. So if it is patient with obesity, with elevated ALT, our go-to choice has to be GLP-1. If we are treating a lean NAFLD patient with marked insulin resistance, nothing works better than pioglitazone. If we are looking for refractory obesity, then dual agonist have shown good results. So hepatic insulin resistance is the central defect in diabetes and obesity, which drives increased hepatic glucose production, liver fat accumulation, and progression from NAFLD to NASH and to cirrhosis. When the liver is the target, glucose-lowering therapies should be chosen for its effect on liver fat reduction, improvement in insulin sensitivity, weight loss, and suppression of hepatic glucose production. Pioglitazone, which is TZD, and GLP-1 receptor RA have strongest evidence for biopsy-proven NASH resolution, while GLP-1 and SGLT2 inhibitors are most effective drugs to reduce liver fat. So weight promoting and of course the weight promoting agents such as sulfonylurea and excess insulin actually worsen hepatic steatosis, whereas therapies that enhance metabolic flexibility like GLP-1 RA and dual agonist, they offer greater potential for disease modification. And with this, we thank you for your patient listening.
Thank you.